Bismillahirrahmanirrahim. First of all, I would like to thank Pakistan Society of Hepatology for their kind invitation in this conference. So the topic assigned to me was liver transplantation for hepatocellular carcinoma beyond the usual or standard criteria. So I will start by looking at the natural history of untreated hepatocellular carcinoma. This is a very old paper from Professor Akuda, and you can see that hepatocellular cancer in a cirrhotic liver, even if untreated, but diagnosed in an early stage, a lot of people will survive up to 1 year, and then some of them actually will survive beyond 2 years. But at 3 years, majority of the patients, even with a smaller hepatocellular cancer, will be dead by 3 years. So it all depends at what stage we diagnose the hepatocellular carcinoma. And when we consider liver transplantation, actually we are looking at the long-term survival of this therapeutic intervention that makes it the best treatment for hepatocellular carcinoma, because liver transplantation not only achieves the widest possible surgical clearance, it also treats the underlying chronic liver disease as well. Milan criteria and UCSF criteria has been fairly established over years, but over time, the thought was that Milan criteria is too stringent, and a lot of people who are beyond this criteria would benefit, but they will be declined from transplantation. So hence, in different parts of the world, most of the centers adopted their own criteria based on their waiting list, financial resources, availability of living donors. So we have a huge list of different criteria. But the bottom line is, which makes a difference in terms of long-term survival for hepatocellular carcinoma, is the size of the tumor and number of the tumors. These are the two morphological parameters which we traditionally have been looking at in terms of the outcome of transplantation. So beyond 5 or 6 centimeter and beyond 3, 4, or 5 number of tumors, the outcome of transplantation is not as good as in the early stage of liver cancer. But still, it is a huge range. There is an additional 50 or 35% of survival which can be achieved if we consider these patients for transplantation. The size of the tumor matters in a way that it is the surrogate marker of vascular invasion. Size per se, I think, is not a bad prognostic marker, but because once the size of the tumor increases beyond 5 centimeters, the chances of microvascular invasion increases. And it is a microvascular invasion which actually determines the long-term outcome. So vascular invasion, which has traditionally been a contraindication to transplantation, has recently been challenged as well. And I will elaborate that in the subsequent slides. The other way to look at the outcome after transplantation is the biological markers. And traditionally, alpha-fetoproteins has been widely used, and now DCP or PIVICA2 has been increasingly used by a lot of transplant centers to predict the outcome after transplantation. Then some centers use retreat score, and then neutrophil to lymphocyte ratio or platelet to lymphocyte ratio has also been studied as the prognostic markers. Increasingly, PET scan is also being used, and whenever patient has high SU values in the tumor, it is thought to be a bad prognostic marker. The liberest of the liberest criteria established or practiced in the world has been in China, in Hangzhou, and Toronto, in Toronto General Hospital. They did not consider the number of the tumor or the size of the tumor as a barrier to transplantation. However, in larger tumors, they tried to do a biopsy of the tumor to get the idea of vascular invasion and the grade of differentiation. And in the Toronto criteria, if the tumor was well or moderately differentiated, they did transplanted these patients. However, for poorly differentiated patients, they were not offered transplantation. But the limitation by doing a biopsy, number one, there is a risk of bleeding, and it is more in cirrhotic liver as compared to a healthy liver. And secondly, by doing a biopsy, you have a small risk of tumor seedling along the biopsy tract, although it is only 1 to 2%, but that matters in those 1 to 2% patients. And the other thing is that degree of differentiation and even the microscopic vasculation at times is very difficult to confidently predict on just a true card biopsy. So that is why it has not been adopted by the rest of the world yet. The other pressure for extension of these criteria in the Western world has been the availability of deceased organ donors, because when you are comparing the outcome of transplantation with benign diseases, then they have to really justify that a patient with an advanced liver cancer would eventually have, if not the similar, at least a good outcome of transplantation. And I think one of the major debate and discussion all around is the resource allocation for these patients, because majority of the patients with hepatocellular cancer world over will present with an advanced stage. And although liver transplantation still remains the best option for them, but in terms of allocating the disease organs and the financial resources to these patients for transplantation actually generates the debate about the principles of justice and how you justify the allocation of organs and resources to these patients. And this is a matter of ongoing debate. And there are a few questions which arise that why should the scarce donor resource be used for these patients with hepatocellular carcinoma? And there is a concept of incremental cost-effective ratios for quality adjusted life years. By scientific formula, you try to justify. And if you look at liver transplantation in a benign disease, liver transplantation is in an incremental cost-effective ratio of 35,000 to 125,000 US dollars. But if you compare it with a multimodality treatment of pancreatic cancer, actually that has an incremental cost-effective ratio of 300,000 to 400,000 US dollars per quality gained life years. So that's the kind of a debate where it is perfectly acceptable to consume huge amount of resources for pancreatic cancer, but not for liver cancer in terms of transplantation. I think resource is one part, but allocating the organ, whether it's a living donor or a deceased donor, that which excites this debate a bit more. And another question is, why the most clinically relevant, what is the most clinically relevant endpoint for expansion of these criteria? So traditionally, the transplant community believes that 5-year survival of 50% has to be the lowest benchmark for offering transplantation to patients with liver cancer. And then you have to justify the harm being done on the waiting list to patients with benign diseases. So by calculating this different Markov models in the Western world, for a hepatocellular carcinoma, if you believe the 5-year survival is 61%, then you can probably offer liver transplantation. But that again remains a matter of controversy and debate. And the other question is whether these criteria should be different in a living donor liver transplant as compared to deceased donation. And living donor, as you know, is a radical treatment option that does not impact the waiting list. And the recipients are not competing for donors, but here their own beloved one is donating an organ. But the question is, it all depends on the willingness of the living donor to assume the risk of his or her own health in order to be able to provide treatment to another person whose outcome might not be that great. If you look at the other cancers, and the principle of surgical oncology would dictate that you should have at least a 20% chance of cure when you are offering a radical surgical treatment. But here, can we justify a 20% chance of cure by offering a living donor liver transplantation, where the donor carries a 0.5% risk of mortality and about 15% risk of morbidity. I mean, I myself could not answer this question. And then the debate become even more interesting when we add the patients in the downstaging group, because you exclude patients because their size is big, their alpha-fetoprotein level is high, and you treat them with local regional therapies and a combination of local regional therapy and immunotherapy in more recent times and sorafenib from last few years. And there is a decent number of patients who are actually at downstage and who are not a transplant candidate upfront, but with downstaging, they can also become a transplant candidate. And that is also another area which need a lot of discussion. So I will just elaborate 3-4 papers around the title of my talk. ASAN criteria from ASAN Medical Center in Korea. They have come up with their own criteria, and they consider the tumor size that is not beyond 5 centimeters, but the number of tumors can be up to 6. So this is a little bit of expansion or extension of Milan and UCSF, and you can see from the curves that the 5-year survival in these patients were as good as within the Milan criteria. Then the Toronto General Hospital, which leads to this Toronto criteria, they originally evaluated the transplant performed between 1996 to, I think it was up to 2002. And in 2006, they published this paper, which is now known as the Toronto criteria, where regardless of the tumor size and regardless of the tumor number, as long as on biopsy, the degree of differentiation was reasonable and there was no microscopic vascular invasion, they transplanted these patients. And you can see from this slide, there was a decent number of patients beyond 6, 7, 8 centimeter in terms of the size. And similarly, in terms of the numbers of the tumor, beyond number of tumors as 5, 6. So they didn't care about the size and the number of the tumor. All they cared was the vascular invasion and the degree of differentiation on biopsy. And then they actually revalidated their paper from 2006 to 2012 with another cohort of patients. And then they pooled all the data of cohort 1 and cohort 2. And I will just share with you the few survival curve, the patient who were beyond the criteria that was considered a benchmark as a benchmark, that was Milan, and the rest was all included in the Toronto criteria. They all have a pretty decent survival. But if you look into the further details, the prognostic markers was actually alpha-fetoproteins. And in the second cohort, they realized that if the alpha-fetoprotein level is more than 500, then the survival of the patient post-transplantation actually drops down significantly. And then from Korea, they started considering living donor liver transplantation for patients who even have a microscopic or a macroscopic vascular invasion. And they categorized the tumor thrombi in the portal vein branches as VP1 when they are at a subsegmental level, and VP2 when the tumor was in the segmental branch, and VP3 when the tumor was in a lobar branch, and when the tumor was in the main portal vein, it was categorized as VP4. So based on this categorization, they transplanted patients when up to the level of a lobar division. That means the right portal vein or the left portal vein, or if the tumor was within the segmental or subsegmental branches. And you can see from these slides, if the tumor involves the right or the left portal vein branch, the survival drops down to 14% at 5 years. But if the tumor was well within the liver in the segmental branches, the 5-year survival was between 63 to 65%. Although the numbers here are small, but it just gives you a taste that there are some patients who still can benefit from transplantation. And if you further look into this paper, I think AFP come out as a great prognostic factor. Like if the AFP of these patients were less than 100, their 5-year survival is approaching 90%. And mind you, we are talking about a tumor thrombus in a subsegmental branch, and then AFP less than 100, and you expect a 5-year survival of 90%, although the number of patients in this group was only 13. On the other hand, if the AFP level was greater than 100, the 5-year survival drops down to 38%. Again, highlighting the importance of AFP as a biomarker in terms of predicting the outcome of transplantation. We were also doing transplant for selective patients who had a macroscopic portal in vein when I was in Shifa. We started doing that based on this Korean paper, which I alluded to. So into what the general policy we adopted was that the size of the largest tumor should not be more than 10 centimeter. AFP, we were always confused, but broadly, we thought with the larger tumors, the AFP level has to be less than 1,000. And then we also looked at the patient's the liver functions. If the patient was in a good liver function, and they can be offered a loco-regional therapy or a systemic therapy with sorafenib, we always try to downstage these patients first and then transplant if possible. But the small group was there who had fallen into this criteria, but they also had a liver failure. So either you offer them a supportive care or you give them a chance for liver transplantation. And some of the patients were also included in this group. And I think the crux of this paper, we recently published this, one of my colleagues, Dr. Abu Bakr, the gist is, again, if patients' alpha-fetoprotein levels were higher, the patient has a bad outcome, regardless the size of the tumor and regardless of the tumor thrombus in the portal vein. We did not selected patients for transplant who had a tumor thrombus in the lobar vein. That means right or left portal vein. We selected these patients who had tumor thrombus in a subsegmental or a segmental branches. And along with that, the AFP was less than 1,000. But once you analyze this data, you can see AFP carries a huge importance. I think AFP level, if it is less than 100, you have a pretty good chance of 5-year survival. And the second cutoff was AFP level of 400, again, is a pretty much decent range that you can accept these patients for transplantation. And again, remember, we are talking about larger tumors, patients with tumor thrombus in the portal vein branches within the liver. If their alpha-fetoprotein level is less than 100, they stand a fairly good chance of 5-year survival post-transplantation. And it is very much clear from this curve here as well. So based on these and looking at the literature overall, I think there is a high level of evidence is lacking for recommending patients for liver transplantation in these advanced criteria. I think Milan and UCSF are the most validated criteria, and they should be used as a benchmark whenever you are considering transplantation. Out of all the extended criteria, UCSF criteria, if we consider it as an extended criteria, is prospectively validated as well. So I will take UCSF as a standard criteria from this point on. There is some evidence, however, that expanding the criteria to, in terms of the number of tumors up to 6 and the size of the tumor up to 10 centimeter, and that is what we are talking about, size of the largest tumor, and the AFP level of less than 600. And then if time allows you, downstage these patients with local, regional, or systemic therapies, wait for 6 months, and then make a decision for transplantation. So a moderate expansion of the number of transplants with HCC can be achieved with this policy. So I would like to conclude here that some patients with HCC beyond the established criteria and portal vein tumor thrombus might have a good long-term outcome. Biological factors like alpha fetoprotein and PPK2 levels actually plays a crucial role in terms of identifying those patients who would have a recurrence after transplantation. Anatomical factors like the level of the involvement of the portal vein branches by the tumor thrombus also have a prognostic value. And then response to the loco-regional therapies and systemic therapies for 6 months or maybe up to 1 year actually give you a good feel of the prognosis. And liver transplantation, however, in patients with vascular invasion remains an experimental treatment at this moment in time. And with this, I would like to thank you all for inviting me and listening to this talk. Thank you.